who else is going to take care of this if not the federal government, right? Who else is going to solve the problem of healthcare in rural America if the federal government isn't?
The shutdown of the U.S. government stretches into its third week this week, and federal employees and everyday citizens are beginning to feel the effects of the closure. Food banks in urban areas are ramping up care to families in need, and rural physicians are wrestling with how to care for dispersed patients, many of them elderly, who had depended on telehealth and hospital-at-home programs available through Medicare and Medicaid. Joining us to understand the shutdown's ramifications for rural America is Kevin Stansbury, CEO of Lincoln Community Hospital and Care Center in Hugo, Colorado, a small town with a population of just under 800 people. Kevin, thanks for joining us on the show today.
It's my pleasure. Thank you for asking.
Kevin, right before this shutdown, you wrote an op-ed for the New York Times voicing some of your concerns about how Congress was wrestling with health care cuts that could affect rural communities. What were your worries at that time, and have they been realized in whole or part over the last 3 weeks of this shutdown?
So the answer is yes, but it's more of an anticipatory fear. Most of the cuts within the Budget Reconciliation Act are delayed for a couple of years, some as many as 3 years. But we're getting ready for them. But it failed to highlight that not only did we not need cuts, we needed more help with our reimbursement. So, for example, my little hospital, 75% of my patients are either Medicare or Medicaid or simply don't have access to insurance at all. With the impact on the premium tax credit, with the potential cuts in Medicaid, and there's also a looming cut to Medicare that no one is talking about that could impact us. That sort of perfect storm coming together is going to be problematic. I also want to point out that 50% of the rural hospitals across the country, and that's true in my state, it's 50% of the hospitals in rural Colorado, are operating at a loss right now. And the last thing we needed was more cuts to reimbursement. Final point I'll make is there's a lot of this discussion about access to benefits, access to health care. Patients generally are still going to get care. I'm just not going to get paid for it. And there's some discussion about folks accessing the emergency department. Well, if nobody pays for that, how do I keep in business? How do I make sure that patients that do have a payer source still have access to health care? So it's a very complex problem, and it's frustrating that we can't seem to get the ear of policymakers that this is something that really needs dramatic change.
Have you noticed an uptick in visits to the emergency room at your hospital or concerns from elderly folks in the last 3 weeks of the shutdown as we've seen the pause or the shuttering of some of these programs that assisted them before?
That hasn't had a direct effect yet. Medicare and Medicaid are both essential programs, so payments continue. Access to health care is still there as it was before the shutdown. The problem with the shutdown right now, in my view, is we really don't have good access to policymakers. CMS is down to the Centers for Medicaid and Medicare Services. They're down to essential employees. So questions on accreditation, rulemaking, those kinds of things, there's nobody there to talk to. Payments continue, but the payments for Medicare flow through Medicare administrative contractors, and there's questions about who they are talking to at CMS to clarify benefit questions and the like. So it hasn't happened yet, but it's coming. And I'm glad, Clarissa, that you mentioned the elderly. One thing that hasn't been talked about a lot, and it's a huge problem in rural, is access to long-term care for our elderly patients. In rural areas, as you all know, our patients tend to be older, sicker, poor. So the need for nursing home services is critical. Yet 98% of my long-term care patients are Medicaid patients. So if material cuts come to Medicaid, how do I tell a resident who's lived in this community their entire life, and maybe in their 90s, how do I tell them I can no longer care for them? Where do they go? The next closest nursing home to me is about 90 miles away. Well, if you're 90, your kids are maybe in their 70s. They don't have the ability to travel to visit you, and it's a problem that we're not talking about that I wish we could address. Last point I'll make, and sorry to go on and on, 20% of rural counties right now no longer have a nursing home. They're just gone because the reimbursement is inadequate, and it's tough to maintain that service.
Russell, how have you seen churches wrestle with what Kevin here is describing about the tension around displacement, even for the elderly, and care in place when health care isn't present for them?
Well, I've seen churches who not knowing how to deal with this because it is a cascading sort of problem. When you deal with the issue that Kevin just mentioned, for instance, with somebody who can't get nursing care, the church has to deal with not only how do we minister to that person, how do we minister to that person's children, adult children who are trying to grapple with what do we do, how do you deal with all the other responsibilities that are coming with that adult children, how do you minister to the people who are in the healthcare profession who are in some cases burned out by the level of care they have to give without any solutions to it. I mean, I think a lot of churches don't know what to do. It's not as easy as saying, okay, we've got somebody with a health issue, let's all take up an offering and help that person. I mean, there are some times when that's the case, but when it's an entire community and the church itself, I mean, if you think about in a lot of these rural communities, the churches themselves are facing the same factors blowing back into them. They're not able to respond or to care, even if they knew what to do. So that's a challenge. It's not just about healthcare. It has to do with people's spiritual lives, their cultural lives, their family lives, everything.
Yeah.
Mike, I think it's really interesting that Kevin says it's been hard to get the ear of lawmakers because over the last 10 years, we've seen Over the last 10 years, we've seen a sort of curiosity about rural America grow. I think about the massive popularity of J.D. Vance's Hillbilly Elegy when it came out. There's also been a caricaturing of rural America. How do you think this tension of curiosity and caricature play itself out in discussions like the ones over healthcare that have really instigated this shutdown in the first place?
Well, I'm really grateful Kevin is here telling his story, talking about what's happening in his community, because I think that's the only way. I mean, listeners to the show will know that I've had no shortage of criticism of Vice President Vance for various reasons, going back before the elections and all the rest. But I think he did write a profoundly impactful memoir because it brought you into the life of that kind of a community. The thing I keep thinking about as we talk about this is that there's sort of two sides of the problem that Kevin's describing. One is bureaucracy is the rule of nobody, right? When we deal with problems with the bureaucracies, whether it's the IRS or it's Medicare or Medicaid or some other sort of federal program, when funding is cut or when there's like a processing problem or whatever else, nobody's responsible. It can be the most frustrating thing in the world. And I imagine, Kevin, you have one of the most frustrating jobs dealing with federal bureaucracy on the planet. I can't imagine, somebody whose situation is more difficult in that sense. At the same time, what this story points us to is the fact that there are some things that, like, who else is going to take care of this if not the federal government, right? Who else is going to solve the problem of healthcare in rural America if the federal government isn't? There's this idealistic thing that often happens among evangelical conservatives, and look, I count myself as one of them, but there's this idealistic thing that happens that says, oh, we need government to be as small as humanly possible, and generous Christians need to step up and take care of the poor in their communities and the charity and all this. The church can't do this. The church can't do the job that Kevin is describing, and it can't respond to this sort of emerging crisis of elder care in rural America we don't have the resources for it, and I think that's a problem that evangelical conservatives have not adequately wrestled with.
Mike, if I can add on to that, one of the challenges we face, I'm an independent rural hospital. It's me. I don't call Dallas or Nashville for permission. I have a local board that's appointed locally, and we make our decisions in what's the best interest of the community. There are a lot of advantages to that. But one of the disadvantages, in addition to the challenges in wrestling with the federal government, is wrestling with commercial payers. If I call a large commercial payer and say, hey, my rates are low, I need to get an increase, I've been talking to one payer for over 18 months trying to get paid what it costs me to deliver the care. And if you look at the analysis across the country...
And just for the listeners, when you say commercial payers, you're talking about like health insurance
companies, yeah.
Yeah.
When you look across the country, independent rural hospitals are paid the least, when I think there's a very good argument that we should be paid the most, because I have to maintain an emergency department 24 hours a day, 7 days a week. Your comment about the government responsibility for this, I tell policymakers in Denver all the time, if you drive east on I-70, you care about my hospital, because I'm the only hospital between Denver and Burlington, Colorado, which is right on the Kansas line. That's 180 miles.
Wow.
And we pick up a lot of patients off of the interstate who have had an incident on the interstate that need to get health care. And if I'm not out here, there's nobody to do that. And I think that's a very compelling conservative case, if you will, that's where government needs to step in and help out and make sure we're paid adequately so we can care for those patients.
So, Kevin, you're describing emergent care there. What about things like opioid addiction and how that has gutted rural communities? What kind of long-term care or services can be possible in an environment, in a landscape such as the one we have with healthcare right now?
It's a really great question, Clarissa. We are blessed in that in our area, we don't have a heavy opioid problem. It exists, but it's not what maybe it is in some of the areas east of us. Our problem is alcohol abuse. Our problem is THC and marijuana and people who fall into depression or anxiety and then try to self-medicate. So a couple of things that we try to do, and I think rural hospitals are very good at this. We integrate our behavioral health services within our primary care services. If you come to the doctor's office and you have, in for your annual exam or chronic disease management, we're always doing an assessment of your anxiety and depression. And if you need help, it's easy for us to get a provider in to see you at the same time. So it's fully integrated, and I think rural hospitals do that very well. And it really relates to a point, a lot of the times, there is sensitivity on policymakers, but they try to take systems that they've developed in urban areas and squeeze them into rural areas. And many of us have been arguing for, no, we're different. Let's work on systems that'll work in rural areas that sometimes we deliver care that is superior to what's available in the urban area because we really know our patients. Right. Let's look at systems that'll work there and then see if they can scale up into the urban areas. And all too often, it's the opposite way.
Russell, I was gobsmacked, honestly, when I read in Kevin's piece for the New York Times that before his group had opened an X-ray clinic in a remote area, residents had to make deals with a local veterinarian for imaging. I can't imagine bringing my child, who I thought had a broken bone, down to the vet where I take my dogs for services to see if he was okay. Are there any lessons that we can learn from the time of COVID where we saw Medicare stretched thin that we could apply to these situations where we're seeing Medicare or healthcare stretched thin again in these rural communities?
Well, I think one of the main things is for all of us to pay attention to it and to recognize that this is a problem for all of us. I think there's this assumption sometimes. If we don't pay for this, if we don't expend the money for this, then we're saving the money. And often what the people who are on the ground, such as Kevin, are saying is it's not just that the horrific human cost here, it also is going to end up costing you a lot of money as a country, as a community, and that becomes a burden on everybody else. And I think it's one of those things where when it comes to health care, often we don't think about it until we're right at the moment where it's directly affecting us. I was talking to someone, a Christian, who admitted to me, look, I never even really thought about Medicaid at all. Now I'm in a situation where suddenly I'm dealing with an elderly mother with dementia. We're trying to have to figure out Medicaid. This person said, I don't even know how people navigate this entire system and know how to make this work. But it's something we haven't been taught to even think about or to care about until it's here. If you have, I mean, what we've talked about, what churches can do, I think one of the things churches can do is to actually not just let people slip away and, once they're in this time of great stress, they're gone and we don't pay attention to them. Find out what's happening and actually talk to the people who can make these decisions to say, look, we're your constituents too, and this is affecting us.
Russell, if I may, Clarissa, that's a really good point. One of the things I think we forget a lot is rural areas is where our food and fiber, our fuel, our clean water generally come from. Rural hospitals are often the economic engine that maintains the viability of rural communities. There was a study done a few years ago by the Federal Reserve Bank in Kansas City that looked at what happens to communities when a hospital's closed. Over a 10-year period, job losses continue, and the communities in many ways are absolutely devastated. So who's left behind to grow the food, to produce the fiber, to produce the fuel, to maintain the clear water? I think it's really important that we look at this as it's really in our national interest to maintain the viability of rural communities and maintaining access to basic essential services. I talked about the distance before where we're at. Right now, east of Denver on the I-70 corridor, you have to drive to Colby, Kansas for the next closest OB program. Mm-hmm. There are only, on all of Eastern Plains of Colorado right now, there are only 4 hospitals that continue to deliver babies. Those are the kinds of things we should look at and say, would we tolerate that in urban areas? No, we wouldn't. Why do we tolerate it in rural areas and just let it happen without really having a serious conversation about how we address those things?
This is a good reminder to pray for those hospitals, the doctors, the nurses, and the administrative staff when you pass that blue H on the highway. Kevin, Mike, Russell, thanks for being with us for this conversation. Listen to the full episode wherever podcasts are found.